Well, thank you for joining us. I really appreciate it.
Glad to be here.
Do you want to just introduce yourself? Name, background, what you do?
Larry Van Horn. I'm a professor at Vanderbilt University in the business school. I'm a health economist. I'm responsible for the graduate programs in business administration and healthcare at Owen.
Mm-hmm. And you work in the business school, but you also teach in the law school and medical school,
I have
right?
appointments in law and medicine as well, and many of my students cross over both into the medical school as well as the law school.
Mm-hmm. And you serve on boards for companies around here?
Yeah, I do a lot in the private sector. So I sit on a number of public company boards and private company boards and work with a lot of the entrepreneurial firms here in Nashville and the private equity groups.
Mm-hmm. And you have your own company?
And I have my own company as well, an analytics company, which has given me a lot of visibility into what happened in light of COVID. So during the COVID initial onset in March of 2020, we actually were asked by our friends in the White House and HHS to provide them a nightly data feed on what was happening in U.S. healthcare. Because while the federal government has access to Medicare data, so they know what's happening in the Medicare population, they were quite invisible as to what was happening in the commercial market. So we were giving them a nightly data feed of what was going on in the country.
Yeah, that's awesome. What kind of insights did you provide?
Well, we showed them very clearly the rise of telehealth, our topic of today, going from 0 to 80x in the period of just 2 weeks, going from kind of March 15th to April 15th. There was a meteoric rise, and showing them by county, by area, the burden of respiratory illness prior to ICD-10 for COVID being identified, and then showed them the diagnosis and hospitalizations associated with COVID.
Mm-hmm. Yeah. So going to the telehealth piece, you saw a massive rise in it overnight because of the pandemic.
Correct.
What facilitated that?
Well, a couple things. One is I think there were certainly policy issues that came into play. Most notably, because this was designated as a public health emergency, it did relaxed licensure requirements across state bounds to support providers in one state providing telehealth services to people in another state, and you didn't have to be licensed in both states. So, so that happened under the public health emergency declaration, and they also increased reimbursement and payment parity for telehealth physician encounters to be on par with what it was for in-person encounters. So both those things were hugely important. And then also there was this very real concern and hesitancy on the part of the population to go and have in-person visits and encounter the medical system. So doing this via technology platform, there was a lot of demand for that in light of the concerns around COVID.
So not only were given the pathway to implement this technology in ways they never were able to before, but they also had like a need to do it. People did this out of necessity.
That's right. And, on top of it, as everybody started working from home, they started basically living their lives on Zoom or WebEx or, Teams. And people became much more comfortable with engaging in this medium. And I think that's one of the big learnings that's come out of this that will persist, is that the nature of work has changed. People actually spend more time at home, working from home, doing things from home. And where people live their lives is how they want to consume medical care. And so, we had this trend going on prior to COVID of shifting care to the home, deinstitutionalizing medical care from on-campus facilities to alternative sites of care. And this really reinforced that. And, the future is, you ask me, my ideal encounter is with my provider on Zoom or whatever platform they have, such that I don't have to deal with the traffic and the parking and the waiting and whatnot.
Yeah, because telehealth is booming, and by virtue of that, home health is booming just as part of the post-pandemic, or I guess, a mid-pandemic shift. But let's talk about utilization before the pandemic. Like, we've had telehealth for decades. It's just never really hit the way it did this past year. How were we using it before?
It was being used in a rather kind of limited way in the commercial market, in part because of the nature of reimbursement. The CPT codes associated with providing a telehealth visit are not paid very well. And providers had very little interest in delivering care in that format. We've had for many years companies like Teladoc who were providing telehealth services, but those were usually part of a benefits plan associated with an employer, and it wasn't something that individuals were basically choosing one-off to have an encounter with a provider. So I think what we did in the light of the COVID pandemic was we opened people's eyes to the use of telehealth and that it's a very good substitute for much of the typical inpatient, in-person encounters that we have with providers. And they became comfortable with that. We increased the payment, so there was an incentive for providers to support it and deliver it. And I think providers, I've talked to many, many providers who've actually found it to be quite rewarding way to engage with patients.
Yeah, that's interesting. And so I guess now, like we've had this year where there haven't been regulations, we've been reimbursing, we've been having this sort of floodgate of telehealth, and now I feel like we're trying to figure out where it's best applied and how to use it in the industry. What do we learn from the past year about which sectors or how it should be implemented?
Well, I think there's going to be a lot of variability as things settle down, and things are already settling down into a kind of a new norm based on specialty. So, cognitively based specialties, internal medicine, pediatrics, family practice, psychiatry, psychology, are where a lot of the interaction is verbal, and there's not as much physical kind of interaction and examination, are more conducive to being delivered over a telehealth platform. So you see in the data that psychology, psychiatry, behavioral health has a very high utilization rate of telehealth. Internal medicine and pediatrics and those specialties, are second in block. When you get to the surgical specialties, much of that has to do with physical exam and as well as doing surgery. So I think what we've seen is post-surgical follow-up. Those types of things can be done via telehealth. And I think that it will be a part of each specialty's mode of care delivery on a go forward, but the extent of use will vary.
Yeah, so I guess what I'm hearing is that it can replace some things, but also it's just being integrated into the care delivery. It's continuing the care and allowing doctors to contact their patients more often, or vice versa, patients to contact their doctors more often than they typically would.
It's a much more accessible form of engaging with your healthcare provider. And so, I think there's a wonderful future for telehealth to be part of Americans' consumption of medical care. The question is as the dust settles, how do the economics of this play out? Right now, we're living in a world of under a public health emergency. It's actually a federal declaration made by now Secretary Becerra and renewed on October 18th, which lasts for 3 months. Each 3-month period extends a public health emergency. Under that, all these things that have juiced telehealth continue. Once the public health emergency ends, all of these forces that have pushed telehealth expire. And so it will be very interesting to see what happens then. Medicare does not have the statutory authority to pay for telehealth the way it is now outside of a public health emergency. It's what there is ability to provide telehealth in rural markets with a certain delivery originating source and receiving source, and that's it. And so one of the big issues that people need to be thinking about is when they finally stop extending the public health emergency, what that's going to mean for telehealth.
Well, what changes would we need to see, I guess, statutory-wise?
You need to pass legislation. Very simply, you need to pass legislation. And if you look at the infrastructure bill that's being contemplated or looking at the Build Back Better, there isn't anything in there legislatively around telehealth.
Yeah.
And that's a problem.
Yeah, no federal. So we need federal, but we do have some states taking action, but it seems to be more of a patchwork.
Well, if at the end of the day, if Medicare beneficiaries are going to get access to telehealth, it's got to be from CMS, and it's got to be legislated.
Yeah, absolutely. So we talked about earlier how people could use telehealth for these just-in-case moments, like when you're at home and you're not feeling well, but you're not a doctor, so you don't really know what's going on inside your body. You'd like to talk to your doctor, but I'm not going to call my doctor to get hit with $150 for the primary visit. We talked about how telehealth could be a more accessible, cheaper way for those just-in-case moments where you just want to check in and make sure that you don't need to go to the emergency department. How do you see that playing out in the future?
Well, so there are. What's interesting is the innovation that's occurring outside of federal legislation to support the needs of targeted segments. So if you look at TV today, you'll see ads for Roman or Hims or all of these types of very targeted services that have a telehealth encounter and then prescriptions associated with it. Telehealth is part of that delivery model. You see examples of, I think it's called Blueberry Health, where they provide moms 24/7 overnight coverage, telehealth, to support them with their new babies and whatnot. And it's very affordable. It's $14 a month for a membership, and then you can make a phone call and get that peace of mind. And so much of telehealth doesn't need to be video. I mean, we've kind of gotten into this mode now where we're used to seeing if I'm going to do a tele anything, it's going to be on Zoom, and you got to have your camera on, and people are normally interacting that way. But so much of telehealth can be delivered just over a telephone. And without a physical exam. But you see more and more use of shipping technology to patients' homes that facilitate remote kind of diagnostics. So these could be ear scopes, they could be laryngoscopes, kind of technologies that a provider can direct an individual at home, look in the ear, and let me see that, and make a determination. So I think that these lower cost options that are very targeted are going to be an important adjutant to the way we've been consuming medical care. I'm excited about it. I think there's lots of opportunity.
Yeah, and you mentioned they don't always need to involve insurance.
No. So it's important. I always have to talk about this at some level. What we call insurance is really not insurance. It's prepaid medical care. Insurance is for high consequence, low probability events. And it's a very expensive way to pay for things. And so we can buy medical care with cash. And there's been a rather significant rise in the use because of the advent of high deductible plans and the prevalence of high deductible plans, people having HSAs, of basically paying cash for medical care. And cash is an efficient form of transaction. The provider gets paid right away, and there's price certainty. I know that I can buy a telehealth visit. I can go on Sesame website, and I can buy a telehealth visit for $49 and swipe a credit card, and I've got it. I don't need to worry about my insurance, eligibility criteria, and whatnot. And so we see more and more provider models migrating to direct payment in cash. That includes a direct primary care membership model. You're paying $50 a month for complete unfettered access to your primary care doc, and they can call you, they can Zoom with you, they can text you, use all those modalities. And when you're doing something through an insurance apparatus, you're much more constrained in terms of what you're going to pay for and how that has to be delivered.
And how are consumers reacting to this?
Well, you see a significant use and growth in these new models, which to me suggests that there is demand for these alternatives. In part, the existing delivery system is complicated, it's expensive, it's price opaque, and consumers are really struggling with, tell me what I can get for a defined price where I know it up front and I can just pay for it. And so companies and new business models that are solving that problem for the consumer have a lot of tailwinds behind them. And that's not only healthcare delivery, it's also insurance. So there's a new insurance company called Sidecar Health, which is an all cash transaction model. There isn't reimbursement through insurance. They basically give you a Visa card and say, "Here's a Visa card. Walk in and pay cash to whatever doctor you want." So because of the complexity that has constrained historically telehealth's use, thinking about non-insurance wedded delivery solutions that are cash-based has a lot of appeal for Americans.
Mm-hmm. Yeah. And you've talked further about how telehealth is going to sort of, I guess, you've talked about how telehealth is going to change the economics of healthcare.
Yeah, it's going to be interesting to see what the long-run use of telehealth does to historical delivery models by provider organizations. So if you think about bricks and mortar, you have clinics, outpatient freestanding clinics with a lot of physical capacity and a lot of overhead. And if 25% or 30% of internal medicine inpatient visits migrate to a telehealth platform, you don't need all that physical space anymore. And it's expensive to cover it. Mm-hmm. When you go to an in-person provider encounter, it's often the case that they are going to order ancillary tests, imaging, all other kinds of things like that. When you're doing it via tele, the likelihood that they're going to be ordering those tests and those lab works and whatnot is reduced. Mm-hmm. And the ancillary revenue to the provider organization is concomitantly reduced. Mm-hmm. And so it's going to be interesting to see if they can create a platform that has positive unit economics simply on the telehealth encounter, mm-hmm. At a price point that people can withstand.
Yeah.
And so I think that has yet to be determined.
Mm-hmm. So I guess more so than just, calling up your doctor and just having a telephone visit, you could have a telehealth platform that also runs like diagnostics or, does different, I know there's like eye screening with visionology.
Sure.
You're talking about having special reimbursement codes or just payments for those extra enhancements to keep revenue coming or?
Well, so I don't know how those are going to play out in an insurance world. In a cash world, anything can go. You're much freer to configure and innovate in a world where you're not worrying about getting third-party payment and agreements from payers to pay. If you can offer something like a valuable service at cash, that cash is king.
Yeah.
And so I'll be very interested to see how that plays out. The challenge right now for the existing delivery model is their cost structure is so high. It's wedded to a physical, the model is, the economics are predicated on a physical encounter. And so if you were to re-envision care delivery on a telehealth platform from the ground up without all of the infrastructure to see people in person, you could probably have a different cost structure and be much more price competitive. And so as those solutions come down the pike, it's going to be interesting to see how the existing delivery system and the bricks and mortar deal with a virtual system.
Yeah, I guess what comes to mind is you say bricks and mortar, like an independent, physician practice versus like MD Live or, a major telehealth service that's just kind of opened up nationally. And when you talked about like licensure regulations, once those are stripped down, I guess, I could get on the phone technically and talk to a doctor in California sitting here in Tennessee.
You can now.
Yeah.
But once the public health emergency chain goes away, you won't be able to.
Right, yeah.
Unless they have licensure in all the states. And there are physicians who have licensure in all 50 states, and there's whole processes by which to do it. But the licensure issue is an issue.
Yeah. So it's just so interesting to me because we've had this year and a half. We've done great things with telehealth. People are seeing a future where it fits in. But I guess if we don't get any sort of, legal update on this, then it could just all go away after the emergency period.
It's important that people understand that what has happened over the last year and a half has happened because we have a stated public health emergency that's renewed every 3 months. When that goes away, the regulatory burdens come back in, the licensure requirements come back in, the payment issues change. And in an insurance-based world, that will impact the demand and use of telehealth.
So if I am a telehealth business owner right now, I would just be terrified about what's going to happen. But it sounds like you are saying, you know, we don't have to play this game. We can step out and have a cash approach and do what we know is right, do what we know is best.
Right. I mean, I think the demand is there. I think it's going to be hard to put the genie back in the bottle.
Yeah.
I think there will be a lot of pressure on the part of Congress to pass legislation to support telehealth access for seniors. But it's notably absent in all of the legislative wrangling that's going on in D.C. right now.
Yeah. Yeah. All right. Well, last question. What gets you most excited about the future of telehealth?
I think the thing that gets me excited is it frees people to live their lives in places they wouldn't be otherwise able to live. I'm a rural guy. and so knowing that I can have a physician encounter with a quality physician and be an hour away supports me living in a space that I want to live.
Yeah,
you don't need to go, and so that I think is something that excites me. And what we've seen here is as people have been freed from the shackles of going into offices, they found they don't need to go in as often, and so it's changing where people are thinking about living. And I think that's a great thing. It opens people's opportunity sets up.
Yeah. Well, I guess the same for physicians, too. I hear that most physicians actually like to work with telehealth. They found it really fulfilling. Yeah. Well, great. I think that's it for me.
Very good.
Is there anything else you thought we should talk about, wanted to touch on?
No, I think we covered it.
All right. Well, thank you so much. I really appreciate you coming in. Your insight's been amazing. And I love this topic. It's amazing to see everything actually take off.